Heart disease is the #1 killer all over the world, especially in the developed countries. Still the #1 killer in the US, killing 600,000 people per year. But the problem is, a lot of times it's a silent disease. 50% of heart disease goes undetected until a heart attack occurs. Sudden death by heart attack is the first presentation of heart disease for men at average age 61, for women at average age 71. Hi, I'm Dr. Kevin Ham from Vancouver, Canada. And today I want to talk about the scans and the blood tests you need to have to detect hidden heart disease. So what kind of scans can you get early, even in your 20s? Or 30s. You've heard of people having heart attacks in their mid-30s, in their mid-40s, certainly in their 50s, and being more prevalent in the 60s and beyond. An easy test that's non-invasive is not to measure the heart, but the neck. You have these two main blood vessels that come off the heart, big arteries, called carotid arteries, that then go into the head to the brain. And these vessels are double the size of the heart vessels, but they also will be clogged with carotid plaque. And these are typically made out of fat and immune cells. What happens is, even before the plaque is seen, you get thickening of the wall in the blood vessels here, and it's called the carotid intima media thickness test. So you can do a carotid ultrasound, which can only be like $100 or so, maybe $150. This is one of the big causes of embolic strokes. These clots over here breaking off and traveling up the bloodstream into the cerebral vessels, causing stroke, where it causes blockage of blood flow and therefore death of certain brain cells, which can be permanent damage, mobility issues, speech issues, personality issues. One of the top 4 killers as well. You can get baseline. First is important to get baseline. This is what I neglected to do in my 20s and 30s and even my 40s. I started getting baseline in my 50s. And me being a doctor, I should have known better, but I was so focused on work, I was too busy to get this done. My friend, who is an executive at a big investment bank, he died of a sudden heart attack when he was 58. He knew he had high cholesterol. He had the lab test done. He was on a drug, a statin drug that lowered his cholesterol, but he did not know that his heart vessels were clogged 90%, 80%. So I implore you to get these tests. And what are these tests? First is a carotid ultrasound that could measure the thickness of your carotid. That will tell you if it's normal to thicken. If it's thickened, it means that plaque is building up inside the walls of your blood vessels. It's called the CMIT, carotid intermediate thickness test. You can also see plaque developing. Late last year, I had carotid tests done. There was plaque there, but they said, you know what, it's not risky yet, because you really don't get symptoms until it's 70% plus plaque. But what they don't tell you is most of those heart attacks and strokes happen from immature, fragile plaque that breaks off and then clots the rest of the blood vessel or travels upwards, causing embolic stroke. It's not just the obstructed plaque that grows and grows and grows over decades, but also the fragile plaque that breaks off and embeds itself down the bloodstream. These are actually more dangerous because there are no warning signs for these. And that's why you have these sudden imminent attacks. Stroke or heart attack causes paralysis or death. So the carotid test is a very simple way of measuring this. And if it's normal, you probably don't have to measure it again for another 5 years or so. If you're younger, in your 50s, I would get it maybe every 2 to 3 years. If you have wall thickness or plaque, I would just do an annual checkup just to see the rate of progress. Because some plaques develop from 5% to 12% per year. So just imagine in a decade, it's growing at 5% per year. It could grow like 50% on the high side. It could be completely clogged in a decade. So you could be normal at 50 and then have full clogging of the arteries by 61, 62 in a decade, depending on your risk factors, because once you pass menopause or andropause, you're at increased risk for the development and rapidity of the buildup of these plaques. So carotid ultrasound number one. Number two, calcium CT heart scan. Now, this test is also non-invasive, but it gives slight radiation. But because it's a fast test, doesn't require a dye to be injected into your veins and your blood vessels. And it's relatively inexpensive in the US, $100 to $300 US. In Canada, it's more expensive, is not widely done or used or recommended by doctors in Canada and not covered by healthcare. I got mine done for $700 Canadian in Vancouver. So it's a lot more expensive. If you want to save some money and you go into the US, book an appointment there. Sometimes there are long wait lists for these tests. Because it is the number one disease, it's a great non-invasive screening test for the calcification of heart vessels. What does it measure? It measures calcium in your heart vessels. Calcium develops in your heart vessels because the plaque over time is a protective measure of your body to seal it off and harden it so it doesn't break off. But it causes hardening of the arteries. This is called atherosclerosis. Athero means kind of like a mush, and sclerosis means hardening of that mush or plaque. So first you get this plaque, then it gets fibrous and hardened, and then eventually it gets made into kind of like teeth or bone, very calcified and bone-like. And this is calcified plaque. And the CT calcium heart scan will measure the amount of calcium. And if you have any calcified plaque, it means you also have soft plaque, not only hard plaque, because hard plaque takes typically decades to develop that process from soft plaque to hard plaque. So if your calcium score, you have any calcium score, especially if you're younger, you should be very vigilant on monitoring this. If you're zero, awesome. You probably don't have to do another scan, probably for 5 years, maybe longer. You just want to measure the rate of progress. It is a bit of radiation, so you don't want to do it too often if you don't have to. If your score is 100 to 300, or even up to 400, this is moderate heart disease. Your risk of a heart attack in the next 2 to 5 years is increased, and therefore you should monitor it more yearly to see how much your calcium score is increasing. And I think if you're over 100, you should consider getting another type of CT scan, which would tell you where the obstruction and plaques are and how much it's obstructing. If that test shows that you have a lot of obstruction, you might want to do an exercise stress test. But you might also want to do a heart flow test, a CT heart flow test that will show you how much blood flow is obstructed past the obstruction. This might get rather complicated, but the screening test would be calcium CT heart scan. If it's positive 100 or more, you might consider, certainly if it's over 400, you should consider a CT angiogram. You could do an invasive one, or you could do a non-invasive one. And I elect to do the non-invasive one, CT clearly. But CT clearly, that measures all the plaque and where it is and how big those plaques are on each of your coronary vessels, only offered in the States. So I also had to do that one in the States. I had high LDL cholesterol for years. I didn't get it treated. It wasn't that. It was relatively high. It's 184 milligrams per deciliter. What I should have got were some blood tests, and I'll go into that a little bit later. But when my friend died in February 2025, suddenly of a heart attack, at his funeral, his wife, who was a doctor, implored everybody to get this calcium CT heart scan. So I got it done. My score came back 500, which is super, super high. Severe calcification, hardening of the arteries. Mid-June, I got a CT clearly, and it showed multi-vessel hardening of my arteries, and my most extreme blockage was 77% in a branch off one of the arteries called D1, diagonal branch 1. 2 months later, I got a CT heart flow that also requires injection and some nitroglycerin to visualize the heart flow. And interestingly, in that 77% blockage, I only had 25% decrease in blood flow. So my functional effective blood flow in that major blockage was 75%, which is borderline. And my exercise stress test the same week showed it was negative. There were no repercussion of that blockage yet. And I'm an avid cyclist, always cycling, but I wanted to know what that heart flow was. I repeated that at month 8, and my functional effective flow increased 5%, 80%. So now my risk is much lower. And if you look at this graph, that shows you even with the same blockages, what your risk is. If your plaque are very stable, ardent, fibrous, then your risk, even at these extreme 70% or more blockages, my risk is only 2 out of 10, despite it being extremely blocking, because the body has protected itself against them from either obstructing so much that causes impairment in blood flow, which is a major obstruction, but also it's not fragile enough to burst, cause a blood clot, and obstruct suddenly and cause a heart attack. I reduce all the high risk, they call it low attenuated plaque or very fragile plaque, fragile soft plaque. I have 0% now. I've reduced my risk drastically on that front. And so what you want to do is, once you know, is have a lifestyle, or you can put a stent in or a bypass. Problem with the stent and bypass, you should do it if it's an emergency or your high risk factors. But the problem is it doesn't prevent future plaques from growing and causing the same thing, but not only in your heart, also in your neck, in your cerebral vessels, in your for your hearing, in your retinal vessels, in your leg vessels, which are much bigger, which people have peripheral vascular disease and pain upon walking. So it doesn't stop the progression of plaque everywhere throughout your body. So you want to, once you know you have this disease of plaque, which everybody tends to have as you age, 60% of 60-year-olds, 70% of 70-year-olds, 80% of 80-year-olds. In the study in the Korean War soldiers, American soldiers who died during the Korean War back in the 50s, they found that 70% already had the beginnings of plaque in their heart vessels on autopsy at average age 22. So it already starts in the 20s and it progresses until it manifests itself in the 60s typically. Sometimes a decade earlier, sometimes a decade later, 10 years later in the female, as we talked about. So those 3 tests, let's recap: carotid ultrasound, the thickness of the carotid, this calcium CT scan to see how much calcium is in your coronary vessels, the CT clearly to show you where those obstructions are and how big they are, how much it obstructs, the CT heart flow that tells you how much obstruction in the blood flow, which is critical. So those are the 3 main scans that you can do that are non-invasive. If you don't want to do the CTs, you could do the angiograms and the intravascular ultrasound, which is more invasive. I didn't go that route, and so I went this route, and I'm going to do the CT scans every 6 months from now on as a case study for myself to see my progress and also to document. So I am risking some radiation, so I have some fail-safes to protect and mitigate against the CT radiation doses every 6 months. It does cost money. It requires me to travel as well. Now, on the blood test side, what can you do? So typically you do screening tests of total cholesterol, LDL cholesterol, HDL cholesterol. That's on the cholesterol side. But cholesterol itself is not bad unless it gets oxidized. Oxidized cholesterol, especially oxidized LDL, can cause these plaques, cause damage to the blood vessels. It eventually builds into plaque. So you don't want oxidation of your LDL. So once you know you have elevated LDL, you want to ask your doctor for oxidized LDL blood tests. Now, this is typically not asked for or ordered by family physicians. You have to ask for it. Another blood test you would ask for if you have evidence of heart disease is you have a genetic factor. And one of the markers of the genetic factor is a blood test called lipoprotein A. The A is in lowercase, little a. So lipoprotein A. And some people have a genetic disposition of having high lipoprotein A, which causes blood vessel damage and plaque. So anybody with high lipoprotein A needs to be much more aggressive. I thought I might have that, but actually my lipoprotein A turned out pretty low. So it wasn't a genetic factor. It was more the diet that I was eating, fried foods, a lot of heated oils, and a lot of sugary foods and junk foods in my teenager years, 20s, 30s. And I didn't stop fried foods until I was 50. So that was kind of the culprit for me. The other things is you want to measure inflammation in your heart. You might not do the specific inflammatory markers in your heart, but it's body-wise inflammation. And the best measure for that is something called CRP, C-reactive protein. So you want to be under 1. Mine is extremely low. 0.2 is virtually 0. I have no inflammation in my body, but I'm certain that I had high CRP when I was younger. I just didn't measure it back then. So I changed my lifestyle drastically when I turned 50. And that's probably the reason why my CRP is very low. You can get more specific markers, but I won't get into that in this session. Another one you can measure and ask for is called interleukin 6, IL-6. This is another general measure of inflammation, and another one would be homocysteine. So we're getting into the nitty-gritty, but if you just chose one of the inflammatory markers, it would be CRP, C-reactive protein. So mark that down. There's one more blood test I want to mention. Apolipoprotein B, ApoB for short. This is a more specific measure of the lipoproteins that damage blood vessels. So you want to see that number low. You want to see it at under 55 to reduce your risk. So your LDL cholesterol, in American terms, milligrams per deciliter, you want to see under 100, I think is good. If you have heart disease already, you want to get it lower. If you can get it under 70 to 80, then plaque typically won't progress. And if you have plaque, try to aim to get under 55, because then plaque can have a chance of reversing. And apolipoprotein B is the same, or under 55 if you have plaque. And the other thing that you want to look at is your HDL cholesterol. Now, this is a calculated measurement of the concentration of HDL cholesterol in your high-density lipoprotein. But this has reverse cholesterol transport, meaning LDL takes cholesterol from your liver to your rest of your body through your blood. But HDL takes cholesterol from your blood and exports it to the liver and also for excretion. So if you want to carve away all the soft plaque, you need a very functional and a high number of HDL. And HDL is only increased, typically, you could increase it a little bit by drugs, but exercise, fasting, that's why intermittent fasting works pretty well to increase this, but it's hard to increase the number of HDL, but you can. And functionally, there are certain foods that help increase the function of HDL. One, which is really, really great, is pomegranate or pomegranate juice, which is more concentrated. It really helps the HDL take the cholesterol out by many different mechanisms. So those are the blood tests for cholesterol. So after I did my calcium CT heart scan, I did my blood test. My LDL was 168 milligrams per deciliter. I decided to go on a low-fat vegan diet because that proved to prevent plaque and also reverse plaque in the coronaries, which I had never heard of 10 years ago. But after I read this book, Preventing and Reversing Heart Disease by Dr. Caldwell Esselstyn, an esteemed cardiac surgeon at one of the most prestigious clinics in America, the Cleveland Clinic, he had proved it and he had written a book called Preventing and Reversing Heart Disease. And so I had read that book and I decided to go on the low-fat vegan. In 5 weeks, I had already halved. I was pretty vigilant about keeping the low-fat vegan diet with no oils. So I elected not to go on a statin. And then by month 3, my cholesterol had LDL cholesterol declined to 61 and my HDL was 62. And I had reversed all the plaque in my carotid. So carotid plaque is much easier to reverse. It can happen within months to years, depending on the protocol you are and the lifestyle and your genetics. And then I expect to reverse a lot of the soft plaque or most of the soft plaque in my coronary vessels in about 30 months. Maybe it might take longer or a little shorter, but it's quite severe. Esselstyn proved that in his best patients, they were able to reverse 100% blockage in their major vessels 32 months, but their LDL was 38, which is really, really hard to lower your cholesterol too. It might require like a statin. It might require other more strict stacking of dietary measures that will lower your cholesterol. But my LDL was low, my triglycerides were low, my HDL was relatively high at 62. I'm also trying to increase that through exercise and some intermittent fasting and even some day fasting once a week. My hemoglobin H1C was 5.6. I got it down to 5.2. My goal is 5.0. So those are my big things. My heavy metals, I did have some minor heavy metals of mercury and arsenic. So I'm trying to detox those. Those are much harder to get rid of. I will repeat those exams every 6 months to see how much heavy metals are eliminated from my system. So those are some of my blood tests. For diabetes, we have 3 main ones. You have fasting glucose. So fasting glucose will determine if you're pre-diabetic or if you're diabetic. So that's basically you don't eat overnight, you get the blood test and a certain number. The other one would be you can ask for a fasting insulin if you think you have a family history or risk, or you have a dietary lifestyle that is prone to diabetes. So fasting insulin will also give you good information. And the third one would be hemoglobin A1C. Now, what is hemoglobin A1C? So we have all these red blood cells. That's why blood looks red. And inside every red blood cell, you have a hemoglobin. And hemoglobin is a protein that binds oxygen and carbon dioxide. So when you breathe, that's where the oxygen binds to, the hemoglobin in your red blood cells. But when your glucose in your blood is high, you start to bind a lot more of the glucose to the protein hemoglobin. So hemoglobin A1C is a general measure of how much your proteins and lipids are bound to glucose. So typically you want a hemoglobin A1C of under 5.8%, and then you're deemed normal. If it's more than that, then you're pre-diabetic. And if it's over 6.5%, then you're diabetic. So you have all these ranges for fasting glucose and for hemoglobin A1C. So those are like the standard tests. If your hemoglobin A1C is under 5.5, that's great. I'm at 5.2 and 5.3, and I want to get to 5.0, which is an average of 5.4 millimolar of glucose average over 90 days. So hemoglobin is the average of glucose percentage, glucose bound to the hemoglobin over 90 days. So you want to see if you can progressively change it over 90 days. Those are the 3 main things for diabetes. Those can be normal, but there's one more test that you could ask for from your doctor if you have family history, which is the oral glucose tolerance test, which is drinking 75 grams of glucose and measuring your blood glucose at 1 hour and at 2 hours. And it needs to be below a certain level. So some people, they are normal on the first 2, but high on the oral glucose tolerance test. And so that would be a third kind of a later test you might consider. There are a few things you do want to rule out if you have evidence of heart disease and a secondary follow-up visit to your doctor, which is check your thyroid, check your teeth for any cavities, and check for heavy metals. These are like the three big things that also may be enhancing the rapidity of plaque development. So I'll leave you with that. In a later session, in a part 2, I'll go even more into the nitty-gritty. I know this is a lot, but yeah, I think health education is much, much needed all over the world. As we educate ourselves on what is actually happening, we can prevent these diseases before they strike. Instead of being like an ostrich that says, I don't want to hear it, I don't want to do it, isn't it better to know beforehand so you can do things beforehand? It's preventative rather than reactive. And I wish I had done this. And so I am trying to educate people. A lot of times we learn by experience, which happens too late, rather than being proactive and seeking and finding this information. So if you can please share this with any of your friends and family to do these screening tests, especially if they're in their 40s, 50s, or 60s beyond, that could save their lives. And they, in turn, as they educate themselves, can tell other people. I've experienced, even though I told many people, they said they would do it, they didn't do it. And later I hear that they had a heart attack or stroke or died of aortic dissection. If they just had the tests beforehand, they could have had the measures to prevent those things from happening. So I implore you, it's the number one killer. It's a big reason why I'm doing these, taking the time out to help educate as many people as I can now that we have social media, it's such a broad network. So please subscribe, like, comment, and help this video travel. Thanks so much, and I hope you great health in your journeys in your life.